neuropsychologist. There were no problems whatsoever. Saw a child who probably taken a fall in class or PE. He's the son of a lawyer, of an attorney on the faculty at Stanford. Again, probably had long-standing learning disabilities, which came to light after being hit in the head. Had nothing to do with concussion. So it sort of cuts both ways. And hits, and this is something I'm sure the panel will consider. One of the things we certainly talk about in the clinic is not all concussions are equal. Someone who's had a concussion as a football player, where they're going to take more hits, that'd be more important than other sports, basketball, soccer. But that's something I'll leave up to the committee issues. The return to play guidelines are seemingly clear, but when you start talking to pediatricians in the community, they're not clear, and particularly for child neurologists. I would say at this point it's certainly a minority of child neurologists in the U.S. who are aware of the return to play guidelines. They know the words, but they don't really know the specific criteria or the specific rules. The being asymptomatic at rest, and this is where it becomes a little bit foggy. When we see a lot of kids with between the acute concussive phase or the post-concussive phase. And what do you do with the child who's 5 months out, 6 months out, 9 months out, like the one I mentioned, a year out, having occasional headaches? Is that a child who can't return to school, can't return to activities? How symptom-free do they need to be? Strength of evidence was all an issue, too. This is a field where the papers are all over the place in different, certainly different specialties, different impact level journals. So the strength of evidence about symptoms prohibiting you from returning is not entirely clear. And again, that sort of ties into the last bullet point of exactly when you are. Are you 2 weeks out, 2 months out, 2 years out? Clearance from a neurologist or pediatrician, again, I've already touched upon that. The understanding for the average child neurologist and pediatrician out there is still low. At this point, the pediatricians are largely referring to the neurologists. The problem is there's a bottleneck with 12 child neurologists in the country, and most places in the country having wait times of 2 or 3 months for visits for seizures, developmental delay, and whatnot. The idea of getting all these kids cleared through a child neurologist is pretty unlikely. Validity of exercises, too. We get a lot of people, particularly in the West, who endorse various exercises, vestibular therapy, PT, but as my daughter's favorite word, the strength of the evidence would be a little bit sketchy. Last couple things I'll be done. So from Stanford, and we're a little bit of an outlier out in Palo Alto, but the role of computerized psychometrics, a sort of shared opinion we have at the university. We're actually the only Division I NCAA school on the West Coast that does not use things like impact. Validity of these things not entirely clear at this point. They've marketed to pediatricians, neurologists, and the like, but right now, really not convinced how they are. The physiology of concussion is still emerging. There's actually an ongoing study through David Camarillo and Dan Garza and others doing high-end exploration of concussion right now. We're actually using these computerized mouth guards, which have orthogonal components to look at vector determinants, and with very high-resolution photography or video to look at the forces that go on. The other thing we're actually in the middle of facing for gender differences is probably a big issue the committee is going to need to deal with, because gender differences have really not been explored. We've heard a lot about football. We get mentioned to women's soccer and things like that, but there are a lot of other women's athletics, field hockey, lacrosse, that are certainly need exploration. So I'll stop there, and hopefully I'm under my 10 minutes so I don't get the hook. I'll sit on down, and I'll leave the last slide, and we'll stop from there. Thank you very much for your attention.
Thank you. Ducks.
Read my charge, or should I just let them know what I'm talking about? Good morning. I didn't have to come too far, just on the metro down from College Park. I've been the team physician there at College Park for 15 years. I'm going to come to you from a family physician's point of view of being right in the field as things happen, and what I see our role is in the management of youth-related concussions. So and our pediatrician, and as a role of a team physician, we're really the ones who are responsible for treating and coordinating care of these athletes that we care of when we see, whether at the high school level or at the collegiate level. We actively integrate all the medical expertise with other healthcare providers. So honestly, when we're evaluating concussion, we're not on an island. We use our counterparts, our pediatric neurologists, our neuropsychologists in the evaluation of those that are not just complicated, but the simple concussions as well. And we must ultimately assume the responsibility around the issues between pulling someone out of the game, dealing with coaches, concussing with the parents, and also the big issue of return to play guidelines. And I think that's where a lot of the questions come back with these young kids: is when is it safe, quote unquote, for these young people to return back to the playing field? Concussion management, as we heard, there is really no training that happens when a doctor goes through residency. Either family medicine, pediatrics, emergency medicine. There's a little bit in mild traumatic brain injury, but the expectation for one to be a team physician to be about this is more expectation unless they do further training themselves. There are trained physicians that go through a primary care sports medicine fellowship. There's aspects of that on concussion, but really to get that formal education, the development in that area before once you call themselves a team physician and be out in the field managing all types of musculoskeletal injuries and all these head injuries that we're here talking about today. Play has been in the literature many times, and when do you let a young person go back into the field of competition? We know that it's really not safe, whether you are pulling someone from a event that day. If you're suspicious of a head injury, a concussion, or something else, they should not return to play. Concussions like I treat abdominal pain. Abdominal could be a simple gastritis, someone per day. Abdominal pain could be appendicitis. You know sometimes right there on the spot. You know, when the score is 21-20 and there's a head injury and you're suspecting that this kid has had a concussion, you pull them out and the coach is eyeing you, you have to your guns and you have to remove that kid from play. Actually, I removed the kid from the field for my evaluation. Once I've established that there's no neck injury, I take them to the locker room. So there isn't that pressure from the carrying themselves, the coach, or the fans. We take them to the locker room and do the evaluation because the emotional stability of that young person becomes more apparent when they're by themselves with a clinician or the athletic trainer, and not going to see that right there on the field. So if there's any suspicion, you remove, and I learned this from a colleague at West Virginia, a neurosurgeon, remove them from the event and do a formal evaluation. Things that can complicate the evaluation of someone with a concussion. We as family physicians and pediatricians and the like, our partners, be aware of what the post-concussive syndrome is. And these are really patients of a concussion that lasts beyond 3 months. When you headache lasting beyond 3 months, when you see the decline in cognitive function lasting beyond 3 months. I'm dealing with a student athlete right now who gets a headache with any type of exercise after a head injury in September. So now we're post-concussive and we're involving our specialty colleagues in the concussion to evaluate what actually is what's happening with this young man and can he return to sports. We hear a lot about that in the literature these days, whether we're overdiagnosing it in our younger adults or whether it's a proper diagnosis. There's current literature that suggests that young people who have ADHD are more prone to concussion, but when you're evaluating concussion and return to play, do some of the symptoms that one has with ADHD complicate the symptoms that we can see? Also, those with pre-existing mood disorders. Do we get repeated injury may worsen someone's depression? Yes, we know that. We also know that depression, if it's present and not treated or untreated, can make the concussion symptoms worse. So these are complications that we have to be aware of. I'm in a unique position where I've had the opportunity to be a team physician for 15 years. So I know these kids very well that I'm taking care of at College Park, and I know their personalities before something happens. And that's that continuity of care, that relationship, that doctor-patient relationship that is critical sometimes in evaluating, and there's a trust issue too. When I have ACL injuries, we see there's a brace on, and we can see the rehab happening. Oftentimes when there's a concussion, there's no bandage, there's no Band-Aid. The young person's just walking around, and sometimes they're looked at or ostracized by their teammates because they don't see an injury being rehabbed. Physical is important, as we can't get them out there on the playing field. But cognitive rest is extremely important as well. We deal with the fact that if the brain isn't functioning properly, can they go back into the classroom and be expected to be competitive in the classroom with their colleagues? But there's also texting, there's their internet, telephone, there's the movies and stuff on TV. In meetings, they're missing all this. But that's cognitive rest, and that's equally important as the physical rest. We're evaluating these young people with mild traumatic brain injury. So as clinicians on the sideline, on the forefront, the ones who are seeing these along with our athletic trainers who are so important to this field, we need to have some kind of concussion management education that's required, not that to go to and practice and be recertified in. We use toolkits like the CDC has to reevaluate. The NCAA has a online presentation now for coaches. When you review courses, as the previous speaker said, something that reviews and goes over the updates like we're having here today. CME activities for those who want to be their high school team physician or sit on our high school board looking at athletic student athletes in medicine at the high school level and the college level. We need more understanding of these neurocognitive assessment tools. The end-all, be-all to decide someone to go back to return to play. They're part of the decision. It's the clinical aspects of the young person is individualized. There should be no standard or rigid return to play guidelines. Each of these is individualized when the young person can go back to their sport, and it should be a progressive kind of process. And that patient relationship, I can't stress that enough. Have a person involved in care of that young person who has a relationship, whether it's their outside pediatrician or the athletic trainer who's seen that student athlete coming in, who has seen that high school athlete come in the beginning and has that relationship and knows that personality of that young person. I think I'm 10 minutes. Thanks.
Well, good morning. Thank you, Dr. Am, and my friend colleague, Dr. Rivera, and the committee for me to be part of this workshop this morning. The two speakers have covered it. I'll cover it one more time. My discussions relevant to this conversation are my work with the National Football League, USA Football, and Pop Warner Football. You heard Dr. Fisher mention the implemented players at Stanford. I am on the medical advisory board for the company that does make those. It's a non-financial position, but I am involved in that instrumentation work. You've heard both Dr. Fisher and Dr. Rooks talk about sports concussions in terms of who takes care of athletes. No one wanted to talk about concussions, so it's very exciting for those of us in the brain injury world that it's a topic for discussion now. I would say to this panel that depending on what to cover, it's clear that no one specialty or no one degree owns this. I would suggest that a licensed or certified athletic trainer many times is the most valuable person in understanding concussion and should be part of a team that makes the return to play decision and taking off the field. This is really a knowledge, training, experience, and interest area. You heard Dr. Rooks talk a little bit about team physicians. I suggest also that team physicians, regardless of specialty, given their interest, training, and presence on the sideline are very valuable in terms of understanding the concussion issue as well as making return-to-play decisions. I would also agree much more education is necessary. The references reflect some of the work that has been done to help push this forward. There are many other clinical references have been mentioned, so no one's this. It's not necessarily even a physician issue. And certainly a team physician for certain situations is in a unique position to understand the acute management. I was to talk about the role of physical medicine and rehabilitation. Having said that, I don't think anybody owns it. What have I learned is a position that may be helpful in the conversation. Let's talk about the rehabilitation piece first. Physicians have comprehensive training in brain injury, the spectrum of brain injury, and I think that this, your physiatrists are not understanding the spectrum of this disease is really important. Otherwise, you don't know what is a concussion and what is not a concussion. You also need to understand this in terms of prognosis. I would also suggest that the way that I was trained in terms of this biopsychosocial model, focusing on function, is helpful in this disease. I think you heard Dr. Fisher mention this. You heard Dr. Rooks talk about a team of providers. Brain injury crosses many disciplines, whether it's physiatry, neurology, primary care, neurosurgery, ENT, or others. but not just the medical side. It's the PhD side, neuropsychologists, psychologists, psychiatrists, and all the healthcare providers. As concussions get more complicated, the same collect people who manage moderate to severe brain injury also be brought forward for persistent concussive symptoms. That training, looking at this and that concept, has been helpful, I think, reflected by what the other people. Why is this so important? I think we have to remember in terms of brain injury that is the front door of brain injury, but you have to understand that traumatic brain injury is a big deal. In terms of death and disability, it's an escalating deal. It's a sensitive issue. Even mild traumatic brain injury can cause significant disability. So I'm very happy as a person who's practiced in the area of brain injury a long time to see attention brought to concussion. In of itself can be relevant. Also should remind us that brain injury as a topic is an important topic. In terms of physical medicine side of physical medicine and rehabilitation, you heard Dr. Rooks talk about the musculoskeletal exam. Again, having a comprehensive training, regardless of your specialty, in the spectrum of musculoskeletal disorders and injury is also important. And using the same model, which is used for traditional brain injury rehab, is also important. A little different team, but the same concept. Certified Strength and Conditioning Specialist is what CS stands for, a licensed exercise specialist, along with the team, because musculoskeletal issues are also often concomitant with brain issues, particularly in sports. Again, makes sense. Not only are brain injuries common, so are musculoskeletal injuries, and not only are brain injuries extensive, so are musculoskeletal injuries. My interest in concussion came from the backside. I trained in moderate to severe brain injury, and then as my sports training progressed, I realized that basically traumatic brain injury would fit the same model. Once again, not physiatry driven, but anybody. And for this panel, I think the issue is the skill set and team necessary to manage concussion, particularly persistent concussion. There are potential pitfalls in concussion care management. The question that there are pitfalls for youth athletes, particularly for injury. You heard Dr. Fisher and Zach Lystet. The law passed in Washington. I've been very involved in that legislative effort. A young man with a preventable tragedy place symptomatic. So the skill set of understanding that youth athletes may have particular risk, different than adult athletes, and the importance of a proper acute care to avoid the rare catastrophic injury, but also to avoid making a 2 concussion into a 2-month or 3-month concussion by mismanaging it acutely. That is a pitfall. The other pitfall is care for athletes with persistent symptoms, and both Dr. Fisher and Dr. Rooks touched on this. I know we're very concerned about the long-term effects of repeated blow head, and while the conversation about dementia is important, I think there's another issue about managing athletes with persistent symptoms, and that is mismanagement piece, which prolongs the disability, which is also a relevant topic for any paper, I think, on concussion. The dilemma is this. This is my phrase work, and I know Kevin Guskovitz was part of this as well. That most high school level and college level athletes get better in 7 to 10 days. It may be a little bit longer for youth athletes. Most do better, but they don't all get better. And it's important to manage acute concussion correctly, but the persistent symptom concussion is also a challenge. Confounders here. I mean, athletes with persistent concussive symptoms may also have persistent cervical pain. As a matter of fact, almost 35% of athletes with a concussion also have neck pain. Is the pain different? Is it a musculoskeletal disorder? The same thing with headache. You know, the same story of these athletes who have traumatic headaches, incredibly common. But when it lasts, it's the only symptom, and you see children home with diagnosed with post-concussion when they really have a post-traumatic headache disorder. You know, it's important to understand that the confounders must be addressed with a skill set, so not everything necessarily is attributed to the concussion. The same thing goes with this sort of physiological and psychological confounders. You talk about post-concussive syndrome, and the challenge now is attributing all remaining cognitive, somatic, emotional, sleep symptoms to the concussion itself. Once a concussion occurs, everything moving forward is concussion-related. Corollary to that is what you've heard about is interpretation of neuropsychological testing, some computerized testing, but also trying to in neuropsychological testing in the presence of persistent symptoms which can affect neuropsychological function or testing, but may not necessarily be due to cognitive deficits. Jerry and others are in the room, and the role of understanding neuropsychological testing, particularly in the presence of persistent concussion, is really critical because it's a confounder in terms of persistent symptoms. The trouble with post-concussive syndrome is the symptoms are sort of broad. Confusion, lethargy, don't feel right. You have to understand that we used to think that the biological effect led to psychological effects. Now it's pretty clear that you have to understand the patient or the athlete at baseline, because clearly previous anxiety is a strong predictor of persistent post-concussive symptoms, either persistent or depression as a result of a brain injury is a huge issue. I think work has been done by people in this room. 50% of patients with moderate to severe brain injury have depression afterwards. It's not uncommon in mild brain injury either. If that's before they're concussed, or if they get depressed because they've been concussed, the recovery can be challenging. Previous perceptions, what the patient's belief systems are, and motivational factors have all been demonstrated with pretty good literature to affect how people recover from a mild traumatic brain injury. And you've heard from the speakers this idea of not treating people with concussion. I think we may have medicalized this issue a little bit. And these confounders, by overlooking or misinterpreting persisting musculoskeletal, cognitive, somatic, emotional, or sleep symptoms, result in a lot of treatment that really doesn't help, and also unnecessarily restricts young kids from academic activities, sporting activities, and social activities in a critical aspect of their life. The other thing for this panel, I think, skews the data on concussion. These terrible consequences to MTBI because of the diagnosed post-concussive syndrome. Many times I wonder if this is really not post-concussive syndrome in terms of organic brain injury, but it is these confounders that appear or masquerade as sports concussive symptoms. So I have to suggest we look at the outcome data with a critical eye. It's not my macerations on this. People in this room who are fortunate like me to be involved in the most recent International Consensus Conference on Concussion in Zurich. And I will see you that after long discussion and presentation of papers by experts around the world, the group did come up with some suggestions. This has not been released yet, so I think coming out soon. But I will tell you that the right group did agree that for athletes with symptoms of more than 10 days, that they should refer to healthcare providers experienced in concussion management and managed in a multidisciplinary way. And I think this is a strong statement that around the world you're seeing endorsed the same issue of being very careful how to deal with concussions that last beyond one or two standard deviations from the usual course of recovery. And I would just suggest that all the speakers this morning have this in one way or another. I don't want to be the only guy to go over 10 minutes, although I always like to have Fred stand next to me, so I'm going to get off the stage here, Fred. The role of healthcare providers in concussion care, you really have to be able to treat acute. If you're going to be an athletic trainer or another healthcare provider, and you're going to be on the field of play, you have to understand the consequences of acute concussion in youth athletes. Critically important to the rare but preventable consequence, also not to prolong acute care, an acute concussion into a chronic concussion. But I also suggest that for athletes with persistent symptoms, if you have that skill set, then you can take care of them if you are someone knowledgeable in concussion, regardless of specialty. But not, I think that we need to move forward to looking at an integrated team to care for these athletes with persistent symptoms. I think it's a way to avoid unnecessary disability with this injury. It is a ball injury only. I spent a lot of my life taking care of football. It's not a male injury. This is males and females, boys and girls, in all contact and collision sports and all recreational activities. It is a pleasure to be here. Thank you.
We now move to the portion of the time where members of the committee have the opportunity to direct questions to the panelists. I would suggest, just in terms of logistics, rather than going to the microphone, Morgan, unless that's going to foul up our recording, I would have committee members stand in place and ask the question. Will that be okay? Oh, so committee members, as you have questions, if you would go to the microphones. But as a courtesy to the panelists, if you would identify yourself and also for the people in the room as you ask your questions. And you can we'll recognize you in the order that you get to the microphone.
Hi. I have a question. One of you mentioned a multidisciplinary team approach to the management of the concussed patient. I wonder if you could specifically say what disciplines you would want to see in a multidisciplinary approach.
I'll go ahead and start. Probably the disciplines you see represented at the table. So certainly primary care, be it pediatrics or family medicine. And then on top of that, some combination of either neurology, neurosurgery, EMR, and probably some of the other support services as well. Pain medicine, physical therapy. Probably also some hospitals are fortunate enough to have a returning to school program, so some sort of education specialist as well.
I would add to that is that we have to involve our certified athletic trainers. They're part of the planning, pre and post planning for concussion management.
Thank you. I need adult supervision. I'm not independent on my ADLs yet. This is our concussion program. We have athletic trainers on the field to play, pediatricians, primary care providers, physiatry. We have a relationship with neurology, particularly for headache, which is the most common persistent symptom. We teach in the ER with our ER providers. We also have a relationship with ENT for the cervical vertigo or vertigo versus central vertigo issues. We do submaximal exercise program as well, so our physical therapists are involved with that. The thing that is very critical for us is the role not only neuropsychology, which is essential, but we also have psychology and psychiatry, other issues that I discussed with you. And of our players, the other thing that we've done in our program, we have a QI process, so we have case presentation, literature review process, because there are disparate training education, so getting everybody in the room on a regular basis and having case review and also literature discussion has been helpful for us as well.
And that I don't want to misconstrue that not every student athlete concussion needs to be seen by all these people, but sometimes when we are diagnosed with a concussion, not seen because we have this big team. There's a question, but not everyone needs to be seen by all these people because it gets sometimes
persistent.
It suggests that as committee members may have questions, just go ahead and line up behind the microphone. That decreases the transition time.
Dr. Medical College of Wisconsin, I was wondering if you would care to comment on the types of rehabilitation, active rehab, vestibular rehab, et cetera, that's out there potentially for concussion.
Thank you. You have a great program. It's fun. I visited you guys not too long ago. They did it on some exercise for persistent concussive symptoms is limited, but that is present is I think is helpful. Vestibular rehab data just in Zurich data was presented, which will be published pretty soon, which showed with proper patient selection, addressing those issues may have some value. Really, this really goes to the assessment piece. Interesting to me that to be admitted to a rehab unit with a moderate to severe brain injury, you have to be able to exercise 4 hours a day. Yet, I heard Dr. Fisher say with mild symptoms after months, then people are arrested for a long time. There's just no evidence that exercise after the acute period damages the brain. So the short answer is the literature on the different rehabilitation strategies, including medication strategies, is limited. I think that there is some literature which is valuable, and I also think that for example, vertigo is a remarkably uncommon persistent symptom after MTBI that needs to be assessed acutely. But I think the some exercise, assessing balance issues as appropriate, are reasonable with limited literature support, and after the acute phase are not damaging.
Just very quick, so on the West Coast, there's an abundance of therapy, and the only thing I would add to that is it just becomes an issue of what's valid for what, because we have a number of parents who are willing to pay cash in hand for vestibular therapy. Some of the therapies are well-funded, others are either unnecessary or there's a lack of evidence for them. So there needs to be consideration toward that.
Right. The assessment piece is key.
Hearing you alluded to persistent headaches. At what point is there a point in which persistent headache is not concussion is not due to a concussion?
It's 90% of concussions are associated with headache. The great majority of those are gone certainly within 2 weeks, I think is a fair statement. The most persistent, if headache is a standalone symptom after concussion, that's the thing the athlete has. I think if somebody's talking about exercise-induced headache, it needs to be evaluated. Cervicogenic headache, headache radiating from the cervical spine after concussion is really uncommon, 20 or maybe 10% only. The great majority of persistent headache post-concussion, let's say after 6 weeks, has a migraine phenotype. This is not appreciated and often mistreated. And so 1 or 2 deviations outside the bell curve. If an athlete sees you after 3 or 4 weeks and their only remaining symptom is headache, it's time looking for a headache workup, necessarily post-concussive workup.
Even though those might not have, like a migraine-type headache would not have existed prior to the injury, but shows up afterwards. Post-traumatic
migraine is not uncommon, and also a pre-existing headache history of migraine delays recovery from concussion, so it can get you both ways. But the development of a post-traumatic headache disorder is not common.
Rivera? You have talked about the important role of the primary care doctor, whose person he or she is really going to be the person seeing these kids in the field and in their offices. What do you think is the appropriate training for primary physicians? What should be recommended as appropriate training for primary care doctors to better manage concussions?
In family medicine, with the large amount of things that we have to learn in that field as my primary care counterparts, I think additional training on top of that. So there's no way to really put this in our current training and get use out of it. A month-long rotation with our neurologist is not going to give us the training for concussion. So I do believe creating a type of experience or requirement that of an evaluation tool at the end and recertification will be probably the best that we'll get. I just wanted to actually go back to the head comment too, and around primary care providers is oftentimes the athlete doesn't know their history, from a child, involving the parent in family history if there's a headache preponderance in the family, or if there was presentation earlier in life, because those 20-year-olds or those 14 and 20-year-olds don't know their history when they're first coming in presenting.
I'd add back to the comment about training. You know, one of the inherent problems in pediatrics training and other residencies is we're very specialty driven. Every specialty wants their month, and probably the answer is some multi or interdisciplinary training. I would call it sports medicine, even though much of concussion is not sports related. But whether there were a rotation that a pediatrician or a family medicine resident could run that encompassed some orthopedics, some emergency medicine, and neurology, that would probably prepare the 21st century physician a little bit better.
Fred, I think that if a provider or other provider wants to do sports concussion, the currently best available mechanism is to do a sports medicine fellowship, because you longitudinal opportunity to see it. And that's why my other side, if you don't do that, though, I think what we have to understand in the recommendation coming forward is you should learn enough not to hurt an athlete. But if they don't recover in the expected time frame, I don't think you can, unless you're committed to it and see it longitudinally and see enough volume. I think if they persist, then it's time to refer.
No, I agree. I think it's more for the vast majority of concussions are going to get better in the week. So what should the primary care doc needs to know? How do we train the primary care docs to make sure they do a good enough job in that first week?
For the first week or two.
I know back there, I want to talk about it, but one of the county school systems is we have a seminar each year for community doctors, and we go over this relevant topic about identification, referral basis, return to play issues, and so having those sessions, and then if you're uncomfortable, creating a network of those doctors, those primary care doctors who are comfortable in taking care of these athletes.
I think there are resources available. This Army here from the CDC, the Heads Up program, to hawk the video that we made, I think that is pretty good. Then, here, I think that for a patient, if this is going to be part of their practice, they have to have exposure during their residency to understand how to stay out of trouble. The big thing is that you get in trouble for acutely taking an athlete out of play, and certain maxims that are important. And then though it has to go to pattern recognition and experience. But educational materials, statements that are available, and then part of the residency being multidisciplinary.
Chris, Children's Hospital of Philadelphia. This is for anyone on the panel there. Are any of your comments modulated by child age, such that your responses would be different if you're talking about a 5-year-old versus a 15-year-old versus a 20-year-old?
Yes, absolutely. I have a pediatric neurologist. We should let him speak to that. But my comments are really focused on athletes, not young children. It's a different issue with young children.
I think younger children, the younger the age, the more cautious. Certainly a lot more cautious. They're unable to express their symptoms. You mentioned vertigo is not common, but a 7-year-old can't really describe vertigo. So I think extremely cautious on those kids. I'm a little bit slower to but at the same time, you have to make sure you don't run the risk of debilitating the child, and that's the bigger concern. You don't want to certainly create a parent who's then beyond hovering.
I think in terms of the cognitive evaluation tools, there are different stage-wise approaches, like developmental, and so there's not one that's standard across the board.
Look forward to a pediatric SCAT-3 that'll come out with the Zurich document. So there's been an acknowledgement that there will be new materials published for our younger athletes in terms of an assessment tool.
So I'm going, Miami Prince, UCLA neurosurgery. I'm going to ask a similar question in regards to age, but let me add gender into that, because one of you mentioned gender, and we are seeing more and more girls playing extreme sports. We see them participating in the Olympics at much higher levels now. And in your practices, do you use gender in trying to manage the patients? Or is that a consideration that you currently practice right now? And add age onto that as well, so girls at different ages.
So gender has become a pet topic because good or bad Stanford, we have referred to Stanford as the Sparta city-state when it comes to academics and athletics. So we have high-level women's competition, and it's clear there are different rates of concussion cross genders for similar sports, and soccer is the one where it's sort of attributed as, oh, they play differently. It's not clear to me that's necessarily true. But in the clinical application at this point, we have a complete knowledge deficit. We're trying to find ways actually to study women's concussion because, as far as I'm concerned, it's incredibly overlooked.
Joe Wright Children's National Medical Center. Dr. Fisher, you mentioned all the discussion about the training needs moving forward. That's already been had, notwithstanding. You mentioned that the proliferation of the lifestyle laws has caused a bottleneck with regard to the actual implementation of return to play. Are there suggestions that you might have about how we can address this in the here and now, acknowledging the knowledge gaps for the primary care practitioners to whom families are bringing these children, and trying to obviate the bottleneck that you described?
It goes back to what Dr. Rivera mentioned earlier. The emphasis needs to be practical, everyday training for the family medicine doc and pediatrician, not for the subspecialist, because so few kids need to necessarily go to the subspecialist. So we need to press that a lot, and we're not doing a good job. It has been studied. I think there's a paper in JPEDS about 4 years ago, and the number of practicing pediatricians who have any kind of CME training in concussion is a bit abysmal.
In your question, are you asking that return to play guidelines to be made by pediatric nephrologists?
No, I'm just struck by we've had good discussion about what's needed going forward, but there are return to play guidelines right now, here and now, that primary care practitioners are struggling to meet. And my question was more designed that Dr. Fisher referenced the fact that primary care pediatricians are referring kids to neurologists, which even creates a greater bottleneck for addressing this issue. So it's really more of a here and now solution as opposed to what we know we need to do relative to education and training for the workforce moving forward.
Just to that end, CDC resources once again, changing culture once again, and as being involved in the legislative effort in terms of delaying return to play for some kids. You know what bothers me about that? Nothing whatsoever. I'll take the bottleneck any day. I mean, I think that this legislative effort was designed with the understanding it would change culture, and you have helped me make that point. We wanted to raise awareness. We realized that saying something is a law doesn't make it happen, but raised awareness and the effort that the law is now in 42 states, we have produced this discussion, which is what we wanted, because there has to be a solution. Simply not knowing, just because it's hard, doesn't mean we don't need to address it. Most adolescents do get better. We're seeing a much increased awareness by parents, coaches, and athletes themselves, and that this may be the last to come to the table. But I think work like this, other efforts will bring this forward as a necessary aspect of training for anyone who wants to be involved in brain injury.
One quick thing. I mean, there is an answer. I can say in California a couple of years ago there was a law passed that every physician had to take, I think, either 6 or 12 CME units in pain and end-of-life care. So you can certainly legislate some ongoing education to today's physician. It's probably on a state-by-state basis, but there's certainly precedent for doing it.
Wong, last question for this section.
Right, Eric Wong from UCSF. I was intrigued by the issue of premorbid condition raised by Dr. Rooks and Dr. Herrings during their presentation. I'm curious to know whether the data is strong enough that we need a additional pre-participation screen or to identify individuals who are vulnerable to this type of post-concussive syndrome, and that can be used as a preventive tool to prevent concussion syndrome.
Well, the PPE that you referenced is very comprehensive in terms of asking about history, and there are several questions now that we also ask about safety, about hurting yourself, and about gun violence. Those are there. So I think those help us with guidance. It's all, truth is answering the question appropriately as that continuity of care piece that I stress when the physician, when the young person is at their doctor's office, is having that complete history. I don't think that there is evidence that supports that one category of people, of a person with, say, ADHD or depression makes them more prone. I think that we have more complications. Personally, that I see in my practice, I have my athletes who have, say, depression or ADHD and then become concussed, is teaching that piece out of what are the symptoms due to actually. Was it the head injury that we lose here, or was it just an exacerbation of those pre-existing conditions?
Yes, and this really goes to the panel in terms of disease burden. The dichotomy of that you have a brain injury, then you have psychological consequences as a result is probably not right. In other words, it's much more complicated. And are predictors for delayed outcome after concussion, which are evidence-based, and those do include such things as ADD, ADHD, migraine, headache, anxiety, depression, but even anxiety, depression, headache in the family are predicted for prolonged recovery. So in the concussion program, we ask those questions, but I guess the issue is 80% of concussions are better in 10 days. And yes, do I think it's better to have baseline data? We are doing it in the NFL. The Zurich consensus statement will suggest that you have baseline data if possible. It goes to what Dr. Fisher said. This is a cost and availability issue. I don't know. Yes, it's better care. Or the answer if an athlete falls outside the recovery curve, you send her or him to someone who deals in this, because while it's uncommon, but when it is present, then the burden of concussion really becomes significant.
All right. With the first panel for very good interaction and presentation and keeping us on time. And we did pick on the West Coasters.